Good morning, guys. I hope we're all sparkly. It's Monday morning. It's a beautiful day, a time to seize opportunities. Now, it'll come as no surprise that we're not impressed with how the NHS treats guys with low testosterone. It is underappreciated and misunderstood, and we aim to redress these inequalities that exist within the NHS and also the private sector, because we're not impressed with how the private sector deals with testosterone deficiency. We need a progressive, logical, methodical approach to testosterone deficiency and testosterone replacement therapy. Common sense medicine. I like it. Now, the NHS should be adhering to the British Society for Sexual Medicine guidelines. These are set out to help physicians in managing men with testosterone deficiency and also providing them with advice of how to manage them with testosterone replacement therapy. Guidelines are incredibly important. They provide clinicians a useful adjunct to their clinical acumen in establishing a safe and effective practice. Safety first. But what have we done with the BSSM guidelines? We've made them even safer. We've also looked at how we can improve other aspects that are not addressed properly within the guidelines to effect a positive change to our guys, like the routine use of HCG alongside testosterone to maintain function and top up with testosterone, because the premise behind TRT should be normalization of your male androgen levels and helping facilitate the normal, natural, physiological processes that occur within the body. We like the idea of working with nature, not against it. So the computer says no. It's much like a Little Britain sketch. I had a very interesting conversation with an NHS GP the other week about a guy that we share care with. His hematocrit came back at 0.54. Now, that is a contraindication to starting testosterone replacement therapy. So obviously the GP was quite concerned and sought the opinion of an NHS endocrinologist who suggested a holiday from testosterone to adjust the route of administration. Kind of shocked, but not really. I've heard it all and seen it all. So we had a very interesting conversation, because the GP originally had a what shall we do? What should we do? We can't have anything to do with this patient. Now he's under private care. We thought it was safe. Now we don't think it's safe. It was quite disappointing. So he had a bit of a knee-jerk reaction, and he had previously agreed to monitor the bloods for this patient, but threw his toys out of his pram and said, we are no longer going to support this guy in his monitoring bloods. So understandably, my patient pretty irritated. So he's put in a formal complaint. The head of the practice, we don't like complaints in GP land. They cause an awful lot of hassle. And we should take pride in our work, and hopefully the patient outcome should be a positive experience. So the GP partner phoned me to discuss this patient. So we discussed in detail raised hematocrit. and the fact that this guy had optimal male androgen levels. He was using testosterone via the subcutaneous route, which is both safe and effective and causes a decrease in the testosterone to estrogen ratio, making it more favourable. So there was no need to adjust his protocol. So what could he do? Now the obvious comment is you'd look for causation outside of the knee-jerk, it must be the testosterone replacement therapy. Now an obvious answer in a young lad is obstructive sleep apnea. So if this chap was snoring and the snoring is getting worse and he'd filled out the stop bang questionnaire, then it would be sensible to organise a sleep study to eliminate obstructive sleep apnea. So your oxygen saturations obviously drop during the night when you're restricting your airway, and that causes fight or flight, and so your anabolic processes do not occur because you become catabolic and you wake up in a fright. And often lots of guys mistake that for lower urinary tract symptoms and prostate symptoms, but it's actually obstructive sleep apnea. So when the oxygen saturations drop, your body responds and you produce red blood cells. So the free testosterone tells the kidneys to release erythropoietin, and that subsequently tells the bone marrow to produce red blood cells to carry more oxygen to the tissues as a compensatory mechanism for this drop in oxygen saturation. So it's a double whammy. You don't get a good night's sleep, so you're not anabolic because you have this flight reaction, and also the anabolic processes produce more red blood cells to carry more oxygen to the tissues. Now the downside of this is the fact that obviously this potentially increases the viscosity of the blood, so your heart has to pump harder to pump the blood around the body to the tissues to supply the red blood cells, to supply the oxygen, and that can lead to raised blood pressure plus or minus an increased risk of thromboembolic clots. So we don't want that. So what should we do outside of this in a young lad? You should also look for hemochromatosis. So you should do iron studies and a JAK2 blood test. Then what should you do? What can you do? Well, what are we going to do? It's incredibly important to take things into perspective. And when we think about guidelines, as we've already stated, they are to give you a guide to safe and effective practice. Can you practice outside of the guidelines? And the answer to that question is yes. When can you practice outside of the guidelines? When you have the clinical expertise to do so. So we have a medical researcher who has reviewed the peer-reviewed research on this topic, and I will put a link to this in the description for you guys to have a read. Everything must be taken in context. So one of the very important parameters that you should be monitoring alongside hematocrit is blood pressure. So it's the combination of raised hematocrit and blood pressure that causes an additive effect and additive risk, and it's a matter of having a balanced, considered discussion and evaluation in order to act in the best interests of the patient. So I'm going to have a chat with this patient. We may consider a very slight dose decrease, because what I find when my levels get too high is my hematocrit does go above 50, And so I know really from a physiological perspective that when my hematocrit creeps above 50, that level is too high for my genetics, and so I reduce the dose. You always have to have a balanced, considered brain when it comes to making decisions about patient care. Now, hematocrit is interesting. I have gone over this topic before in a couple of other videos. There is debate between the bozos, but you should never promote dogma. You should always act in the best interests of the patient and make your decisions based on the evidence and the person sat in front of you. Because we are the patient advocate, and we all must always be objective. So somebody subjectively may say, I feel great, but if the other parameters that we're monitoring are becoming abnormal, you need to act in the best interest of the patient and say, listen, we need to do this, this, this. We want you to feel great, but understand that testosterone replacement therapy is about long-term physical and psychological well-being. You've placed your trust in me to give you that, so let me do my job. Lance Armstrong, obviously famously known for using performance-enhancing drugs for Tour de France. Let's not kid ourselves, they were all doing it. He never had his hematocrit above 50. Now, most lab reference ranges go up to 50 now, and above 50 you can have some negative symptoms. Paradoxically, lethargy, dizziness, malaise, and lowering your hematocrit below 50 can reverse those symptoms. Now, why did Lance Armstrong only want his hematocrit up to about 50? Because that's where maximal performance was for him, and I think for most people, quite frankly. So that's anecdotal, because guys that do reduce their hematocrit to below 50 from it being higher feel a qualitative improvement in their sense of well-being. So endurance athletes have something called a sports anemia. Now, what is that? Now, they have more plasma than the average schmo to carry oxygen, carry waste products from muscle metabolism away from the muscles to the kidneys to be excreted. So they don't normally have a compensatory increase in their hematocrit or red blood cells. So these naughty Tour de France guys, through either blood doping or using EPO and or using testosterone, wanted to produce more red blood cells to compensate for this relative decrease in the red blood cell count to the plasma volume. So to maximize performance, what they wanted to do was increase red blood cells to increase the oxygen carrying capacity and supply of oxygen to the muscles for exercise, and they used to balance this out with the plasma volume. Incredibly interesting, isn't it? So what we should be doing is using the guidelines, adhering to the guidelines, and only digressing from the guidelines if you have the evidence to do so. We should always act in the best interests of the patient, recognizing that guidelines are there much like the law. They have to apply to the lowest common denominator, and they are always there for your safety. You must always be confident that your prescribing clinician knows their arse from their elbow and is acting in your best interests.